welcome to In the Trenches. I'm David A. Cohen. I haven't made a YouTube video in quite a while. Today I was asked to talk about GI bleeds. This is a broad topic, okay? I'm going to talk about acute GI bleeds first. This is someone who presents to the emergency department with acute bleeding visible blood. Okay, so the first thing you're going to do, you're going to want to distinguish between upper and lower, but the first thing you need to do is look at the hemodynamics and make sure this patient is not going into hemorrhagic shock. So obviously you want to look at the blood pressure. If somebody's actively bleeding, you're not going to stand them up to check for orthostatics. You know, if they're stable, you might want to do that. The heart rate will go up first, so that's very important. You want to assess for stability, and you want to get an IV in. And you may need a large bore IV depending how fast they're bleeding. Okay? After that, obviously, you're going to get blood work and understand that the H&H may be hemoconcentrated. But you have to assess vital signs first. Then you're going to make the distinction between an upper and a lower GI bleed. Okay, so with the lower GI bleed, it's usually hematochezia. The blood is red. If it's on the right side, it may be maroon. Left side, it could be bright red blood, and part of that depends on the transit time. If it's an upper GI bleed, it's often melena, it's blackish, tarry. If it's a rapid bleed, it may be maroon. So maroon stool could theoretically be an upper GI bleed. And you know, you kind of want to make the distinction. You're probably going to want to type and cross some blood and maybe transfuse, but you want to have the blood there for you. Then you do your history, provided they're stable, and you want to find out the risk factors. Okay, does someone have cirrhosis? And are they at risk for esophageal varices, or do they have a history of varices? Very important. Is somebody vomiting and vomiting and vomiting, and then you see blood? That might be a Mallory-Weiss tear. Are they taking non-steroidals? And non-steroidal anti-inflammatory drugs could cause bleeding across the entire GI tract, but it's often in the stomach and duodenum. Do they have a history of peptic ulcer disease? And usually peptic ulcer disease is Helicobacter or NSAIDs. That's what causes upper GI bleeding. You want to make sure they don't have epistasis and it's dripping down their upper airways. Do they have a history of upper GI bleeding before? In this scale, there's something called the Glasgow Blackmore scale, I think that's what it's called, which kind of risks assess these patients based on heart rate, hematocrit, blood pressure, presence of syncope, and other things. You can look that up. Lower GI bleed. Most often, these are due to diverticuli. Sometimes they're due to AVMs. And of course, does somebody have a history of inflammatory bowel disease, which could affect the entire GI tract more often, the lower GI plaque. Neoplasm usually doesn't cause overt bleeding, more microscopic bleeding, and if it's macroscopic, it is not catastrophic. Do they have a history of recurrent bleeds? Do they have a history of diverticuli? So you want to make, and the scale that could evaluate the severity, this is called the Oakland scale. You could get this on MD app and plug it in. So you want to make that distinction. If it is an upper GI bleed and it's continuing, you're going to have GI come in, okay, and you may need to do endoscopy, and especially if there's concern with esophageal varices, they're going to have to do endoscopy and ban the varices. They're going to need to be on beta blockade, but it admits to the acute bleed, they're not going to be on beta blockade because it can affect the hemodynamics. You're going to put them on an IVH2 blocker, usually protonics. And even if it's a Varix, the non-acidic environment could lower the rate of bleeding. So one way or the other, until you establish what's going on, they're going to be on an IVH2 blocker. Obviously, you're going to be MPO. We used to, back in the day, put NG tubes. I've been trying lavage. That's not done as much, but you're going to go in and do endoscopy. If it's a lower GI bleed, the test that's done now most often is CT angiography. And this will locate where the bleed is. They used to do bleeding scans, and if somebody is a contraindication to contrast media, then you might have to do that. This will kind of give you an area where the bleed is, and then if you need to and the bleed persists, you're going to need to do an angiogram and possibly embolize, gel phone embolize the bleeding. Sometimes if it's an upper GI bleed, the GI docs are going to use laser probe and they're going to stop the bleeding via procedure also. So if it's due to a bleeding ulcer or visible vessel or something, the bleeding's persistent, they're going to do a procedure also. Lower GI bleed's usually done by interventional radiology. Once this stops, the acute process stops, patient's going to be in the hospital, you're going to see where their hemoglobin is. Then you're going to go through an evaluation. With lower GI bleed, you may need a colonoscopy. Now, if they have a history of recurrent diverticular bleeds, they don't necessarily need a colonoscopy. If you have multiple bleeding, then you're going to need surgery. Normally, if there's one bleed, you're going to let it go and follow them. They'll need to be on high residue diet. If they have an AVM, that's something, sometimes they could be cauterized. You have to see where it's located. Once in a while that could be associated with aortic stenosis. It's known as Hyde syndrome. If you're examining a patient and you hear aortic stenosis murmur and they have a lower GI bleed, you could think of possibly an AVM. The idea is to stop it, and if you can't go to interventional radiology, and God forbid they can't stop it, the patient may need to go to surgery. Upper GI bleed's a little different. You're going to get GI involved, they're going to do endoscopy, and they may do some form of cauterization or something to obliterate the bleeding. And if they have an ulcer, you're going to have to evaluate them for Helicobacter. And if you're actively bleeding, you can't do a breath test or a stool Helicobacter antigen. You'd have to actually biopsy the ulcer and culture it and look for Helicobacter in the stain. That's GI bleeding in a nutshell, common cause of admission. I'm going to hold on the outpatient evaluation of GI bleeding. Let's cut.